Greetings, Alliance members. We're very excited to host our November webinar entitled Primary Care Focus Interventions to Improve Access to and Delivery of Care to Vulnerable Patients. Today, we have Dr. Nathalie Huguet. Dr. Huguet is an associate professor in the Department of Family Medicine at Oregon Health and Science University. She is a health services researcher and implementation scientist. Dr. Huguet's work focuses on identifying strategies and investigating the effectiveness of these strategies targeted at improving access to and delivery of primary care services among patients from socioeconomically disadvantaged background. Dr. Huguet is a multi-PI of the Building Research in Implementation and Dissemination to Close Gaps and Achieve Equity in Cancer Control in one of 7 NCI-funded centers. Within this center, she leads the multidisciplinary scientific research program. She is also co-chair of the CDC-funded Natural Experiments for Translation in Diabetes Collaborative, studying the impact of healthcare policies on access to and delivery of care among patients from community health centers. Our webinar's format is standard. We will have about 45 minutes for Nathalie's presentation and 15 minutes for Q&A session. Please feel free to drop your questions in this chat box, which Marcia and I will be monitoring. With that, I'd like to welcome Nathalie. Nathalie, please feel free to start your presentation. Welcome to our webinar.
Thank you, Eskar, for this lovely introduction, and good afternoon, everyone. I'm delighted to be here today to share our research finding on access and delivery of care among patients from socioeconomically disadvantaged background. First, I have no conflict to declare, and this program of research is and has been funded by various funding agencies. And the views presented here are those of me and my team, and does not represent that of the funders. So I'm just going to jump right in, and I want to start with a little reminder about the Affordable Care Act, which was enacted in 2010. This large bill targeted various healthcare access and delivery gaps and patient protection, as you can see on that diagram. And the most commonly known provisions, of course, are improving access to health insurance via either eligibility for Medicaid expansions, allowing adult children to stay on their parents' plans until the age of 26, and of course, creating the health insurance marketplace. The ACA also protected against various different healthcare-related fraud, improving healthcare quality measures such as meaningful use and EHR, ensuring mental health care parity, removing out-of-pocket expenses for preventive services, and protecting patients with pre-existing conditions from being denied insurance. So it was really a big package that was trying to improve access, reduce cost barriers, improve preventive care, and somewhat control costs, and most importantly, was aimed at reducing health disparities. So as you can see here, those are the Medicaid eligibility expansions. So the expansion for Medicaid was, the point was all states were going to expand their Medicaid program, which was a big part of the ACA, but was also very contested and led to Supreme Court decisions, and then it was a state decision. So the recommended increase was FPL at or above 138% for adults. And then back in 2014, that's the map on your right. It was about 27 states that implemented some kind of an increase in their eligibility at the time. So, for example, Wisconsin is orange here, but they did increase up to 100%, which is better than 0%. And today, well, sort of, in July 2023, 41 states have expanded. So quite a bit of states have expanded Medicaid. Some have requirements, work requirements, but at least there's a lot of states that have expanded. But back in 2014, this very big difference between the expanded state and the non-expanded state created this natural experiment where we could really compare what happens when you make that expansions and the benefit or not of health insurance expansion. So the research I'm going to present today is based on data from primary care safety net clinics. And these are FQHC, rural health centers, and FQHC lookalike. So here, this slide is from HRSA. So those are funded health centers or federally qualified health centers. And you can see there's 15,000 sites across the US, which are represented within 1,400 health centers. And they care for 30.5 million patients. So a lot of patients are getting their care in these health centers. And as you can see on the right, they are mainly caring for a large proportion of uninsured patients, publicly insured, which is mostly Medicaid, and the vast majority of low-income patients. And 65% of these patients are from racial and ethnic minority groups. And they also cover a large proportion of rural areas. So these health centers and the patients they serve were the most likely to really benefit from the ACA program. Now, I know this is a really busy slide, but it shows the data source from the research that I will share. So the previous slide really described the US health centers, and then this one describes exactly the data that we are using, which is the advanced database, which is led by OCHEN and is a network of community health centers mainly. There are few private primary care clinics, which are not health centers, but the vast majorities of these health centers are community health centers that serve low-income individuals. This is a snapshot of today. At the time of the research that I'm going to show, it was early on, so there was way fewer clinics. There was about 600, but this is a network that is continuously increasing. And you can see they have over 2,000 clinics in 39 states for millions of patients. Also, you can see on the pie that most of these patients are low-income patients. So this is a database of EHR data, primary care EHR data, so outpatient only. So the first thing we wanted to study, of course, is health insurance access. So this graph shows the percent of visit paid for by either Medicaid, private insurance, which in the case of these health centers is mostly marketplace insurance, post-2014, and self-pay, so uninsured. So over the time in state that expanded, which are on the right, and state that did not expand Medicaid, which are on the left. So the first thing you can see maybe is the blue bars. So the blue bars show the changes in Medicaid visit. And we see no change in expansion. You can see how it's kind of pretty much flat, and then big increases in the states that expanded Medicare. It goes from 35 to 40 to 54, not much change between 2014 and 2015. Then the other big changes is the orange bar. These represent the uninsured. And what we see is that the decline, both in non-expansion and expansion, you see the drops, which is good, but clearly the drop is bigger in expansion state. And then the gray bars are changes in private insurance. And here you can see the big increase in non-expansion state, and then no change in expansion states. So these results is exactly what you would expect from what happened with the ACA, that states who did not have an expansion Medicaid have higher uptake of private insurance, and states that had expansion of Medicaid don't really have an uptake of private insurance. And then there's a decline in uninsured, which is good. The last comments on these results is that the non-expansion state, the orange bar in 2015, is still the highest of these three bars, while in expansion state, it is the lowest, which means there's still a really large proportion of patients who remain uninsured in non-expansion state. So we wanted to know who remains uninsured following the ACA. And in this study, we identified patients who were uninsured prior to the ACA, either in 2012 or in 2013, and when we followed them in 2014 and 2015. So these are the same patients. And we looked at their trajectory, and they can either remain uninsured, they can gain Medicaid insurance, they can have no more visits during our period, or have other insurance, which can be private or other public. I should note that we do see in our data a relatively large number of patients, mostly younger adult, who only have one visit, and then they don't ever come back. So that, that is a big chunk of people. But we did look into whether there was large attrition, and we did see that for these health centers, and I'm not showing the data here, but for these health centers, if we look at attrition over a 3-year period, it's about 30%. If someone has more than one visit, about 30% attrition. So that means 70% at least have some visits, more than one visit over a 3-year period, which is good. The bottom line of this table is who remain uninsured. Well, they are mostly patients of Hispanic ethnicity and young to middle-aged adults. We also look at private insurance and the change over time. We wanted to know if the removal of the individual mandate and the cost-sharing subsidies, which were in 2017, would lead to a decline in enrollment in marketplace insurance for these patients. So we look at the change of percent of visit paid by private insurance and the percent of patients who retain insurance. And then we looked at in expansion and non-expansion. So you can see in this graph, as expected, the non-expansion state have an increase, which is much higher than the expansion state. The percent of visit paid by private insurance is continuously increasing over time, which suggests that more and more patients are enrolling in marketplace, including through 2017 and after 2017. We also see clear seasonal patterns here. It increases and it drops, increases and it drops. It really follows these seasonal patterns, which suggests that patients are timing their care, which is likely linked to first having health insurance and then spending that deductible. But that, of course, has implication for continuity of care, especially for the patients who have chronic care management needs and may have like visits gaps or care or choosing that timing of care, rationing their care. So that was good to see that patients continue to be enrolling in private insurance following the 2017 removal. Of course, one big element we want to look at was whether or not there was reduction in health disparities, because that's what the ACA, the big push was to reduce health disparities. So we looked specifically at the change in health insurance access among Hispanic, non-Hispanic, white, and non-Hispanic Black. And we have fewer patients of other race groups, which makes these estimates less reliable. So that's why we're only showing these three. And these figures are pretty clear. You can see the decline over time in uninsured visits. So this is only uninsured visit, and then the three colored line are blue for Hispanic, orange for non-Hispanic white, and gray for non-Hispanic Black. So you can see that in both expansion, so that's expansion is on the right, in both expansion and non-expansion, there is a decline. You can see that the decline is larger in expansion state. But what you can also see is that the gap between the blue line and the other lines does not really decline. So it shows that this disparity between Hispanic and the other group doesn't change. And when you look at Medicaid insured visit, in expansion, in non-expansion state, basically nothing much happened. These gaps stays the same, and actually looks like to have lower visits paid for by Medicaid, and that gap between them and the other groups remains. And then looking at privately insured visits, again, what we see in expansion makes sense. There's not really a change there. And then in non-expansion, we can see increases in the uptake of privately insured visits. And this time, the Hispanic closes the gap and actually have more visits paid for by private insurance than white and non-Hispanic Black. So it seems like the marketplace did reduce the disparities that existed prior to the ACA for privately insured visits. So the bottom lines of these three slides is the lower rates of uninsured visits was for all racial and ethnic groups across expansion and non-expansion. So that's great. That's progress. That's good for CHC patients. But clearly, this progress is not uniform when comparing expansion with non-expansion and all racial and ethnic minority subgroups. These findings suggest that there is a need for continued and more equitable insurance expansion effort to eliminate these disparities. We also were particularly interested in chronic condition detection, management, and control. I will only show slides about detection, but we did also show that the ACA was associated with better management and better control. So here we wanted to know the impact of removing pre-existing condition, stipulation of health insurance prior to the ACA. As a reminder, this referred to private health insurance being able to deny coverage or charge larger premium to patients who had a pre-existing condition at the time of enrollment. And the Kaiser Family Foundation did a survey of these insurance groups prior to the ACA to identify what condition made that criteria. And these conditions could include or included diabetes, cancer, many mental health-related conditions, and many more. So we use that list from the Kaiser Family Foundation to identify what were the rate or the frequency of these pre-existing condition. So this is what we did here. So this here shows a sample of patients, again, who were uninsured before the ACA. So all of these patients are uninsured, and then they either gain Medicaid or they gain private insurance. So the blue bar here, they show the percent of these patients who were uninsured, and they had one or more of these pre-existing conditions prior to the ACA. And this really shows that more than 50% of these uninsured patients had at least one of those conditions and would have had a really hard time getting private insurance prior to the ACA. Post-ACA, the same patients in orange now have gained some kind of insurance, and they had more conditions detected. And you can see now that over 70% of these patients have at least one or more of these conditions that before the ACA would make them ineligible to get private insurance. So this really highlights two things. One, the unmet healthcare needs that these patients were having prior to the ACA. They had a lot of conditions. They had conditions that were not detected, and they had no insurance. And it also highlighted the critical role of the ACA in getting these patients health insurance, and as a result, getting diagnosed with conditions they had, and also the importance of what these policy decisions can have on these patients and their protection. There was a lot of discussion for a while about removing the pre-existing condition provision, and you could see how that would really negatively impact these patients. We looked at changes in diabetes and hypertension incidence, which are the two most common chronic conditions. This is incidence, and this graph shows the percent change in incidence, not just prevalence. And you can see the enormous increase in diabetes new diagnosis in both expansion and non-expansion, but more than 25% increase. That's really large. And in the hypertension, there was a little bit of an increase in expansion and a little bit of a decrease in non-expansion. So maybe less impact on hypertension. That's a really prevalent condition. But it's clear that these conditions didn't suddenly appear, right? These patients were living with these conditions. They had unmet healthcare needs. They had undetected conditions, and then they were able to get their conditions diagnosed and managed. Another important provision of the ACA was targeting mental health parity. And we assessed whether or not there was changes in diagnosis of mental health related disorder. And again, this is that same group of patients who had no insurance prior to the ACA, and then they either gain Medicaid or private. And the blue bars are, again, the pre-ACA trends. You can still see that there's a pretty large percent of that population who had at least one mental health disorder or an alcohol or substance use problem. And then following the ACA, after gaining these health insurance access, there is quite a bit, again, of an increase of the percent of patients who now have these diagnoses and can get those conditions treated. Of course, a lot of, getting these new conditions is directly linked to having preventive services. So we also wanted to look at changes or improvement in access to preventive services and being up to date for preventive services. And again, I want to reinforce that this is EHR data. So every single patient here had a visit. So they had a visit. We don't know what happened in between the visits, and we cannot say anything about those who didn't have visits. So they all are getting care because these community health centers serve patients regardless of insurance prior or after the ACA. So we looked at changes in colorectal cancer screening. So with the removal of cost sharing, you can think of colorectal cancer screening as one that might be more challenging prior to the ACA. The colonoscopy could be quite expensive if you don't have health insurance and you have to pay out of pocket. So removing these out-of-pocket costs could really help, especially for this one. So we assessed the prevalence of patients who were up to date with colorectal cancer screening or test, and that includes both colonoscopy and FOBT, FOT. So the lighter green and orange bar are the pre-trend, and the darker green and orange bar are the post-trends, with green being expansion and orange being non-expansion. So the first result that you can see here is that overall the prevalence of up-to-date status during that period is relatively low here. And the second is that you can see increases across all the groups, in expansion and non-expansion, among those who had a Medicaid, private, or were uninsured. So everybody is increasing. That's great. It may be surprising, though, to see uninsured increasing, but these CHCs will care for everyone, regardless of whether or not they have insurance. There are some programs that can assist patients who do not have health insurance in getting colorectal cancer screening from the CDC. And so that might be part of the reason. Another reason is that these health centers during that period were doing a lot of QI and a lot of targeting improvement in colorectal cancer screening with the uptake of the FIT and FOBT. So there is like this increase in general from within the clinics on what they're doing. So it's a little harder for this specific trends to determine whether it's like ACA related or some other QI quality improvement that the clinics were doing. This is the same trends, but for cervical cancer screening. So same population, same green and orange. Again, what we're looking at here is the prevalence of up-to-date is about 50%. So that's not very high. All the bar goes up, which is good, but the changes are much smaller than compared to the colorectal cancer screening. There's some change, but they're not very high. And then also the uninsured group also did increase. So as part of our Bridge Center for the Implementation Science, we wanted to assess the overall performance of US CHCs. And so we used the UDS data, which is HRSA data. And UDS data are each of these funded health centers have to report quality metrics to the HRSA, and they're made publicly available. So 3 of those quality metrics are colorectal cancer screening, cervical cancer screening, and tobacco and cessation intervention. So we wanted to see if there was more changes over time since the ACA up to 2019. There are data for up to 2022 now, I think, which kind of shows a slight decline. It does show a little bit of the pandemic effect. But here we stop at 2019. And so what you can see is that the colorectal cancer screening continuously increased since prior to the ACA. And it would be really hard to say, this is where the ACA made a difference in this one. And it seems to be related to the efforts, the FFIT and the FOBT on the quality improvement that clinics are doing. So whatever they're doing, it's working. The prevalence is still low, but it's improving. If you look at the cervical cancer screening, which is the blue one, you see no change. Pardon me. There's been no change pretty much. There's little movements, and maybe that's what we saw during the ACA. Of course, this is all health centers in the US, so it's even more health centers than what we were showing. But really, it's not improving. It's not changing. Whatever strategy are currently being implemented to make changes are not working. And then the last one is the tobacco cessation intervention. So this one is a little more tricky. In this case, tobacco cessation intervention, as defined by HRSA, can be that you had the clinicians would have a discussion with a patient who is currently smoking, or could refer medications, or could refer to the quit line. So it goes from a simple discussion to a simple quote unquote to the quit line, but that is counted as, yes, I did a tobacco cessation intervention. So it's unclear exactly how much the variation in intervention by clinic and even clinicians. So it's pretty high, which is good, but one thing it is not 100%. So there's still room for improvement. And again, this is pre-pandemic. And this is the pandemic. So when the pandemic hit, we were evaluating as part of the bridge the uptake of a clinical decision support tool that could improve cervical cancer screening. And we needed to figure out how the clinics were surviving the pandemic, just so that we could understand what we might, how that might impact our intervention. So we were able to get some data quickly and interview health system leaders and clinicians to really understand how are they handling cancer prevention, telemedicine uptake. These 3 graphs show the actual number of procedures. They are not an up-to-date status. And they're pretty clear. You can see the huge drops in procedure counts at the onset of the pandemic. And then there's like the slow recovery to almost baseline in each of these. And what these tell, I mean, what the questions I have when I look at these is, what happened to that patient who didn't get their PAP here? They needed they were due, maybe they even had an appointment, and then they couldn't have their appointment. When did they get that? Did they get it on the next month, or are they still waiting? How much delay for the patient here? How much delay for the patient here? And what are the impacts of these delays? So I don't have any answers for these questions. But that when I see these graphs, that what worries me and what questions. It was also very interesting to get some point of view of the clinic, the health systems and the clinicians. So we learned some clinics had more resources and were able to handle the pandemic very differently than others. They had mobile van. They went to the house of the patients and provided their care. Some other clinics said, well, we're the only clinic around, so we're not closing our doors. And some other clinics were telling us, well, we told our patients who have chronic health problems just not to come. And we weren't prioritizing cancer screenings. We were just doing acute treatment. So it's very interesting. If you want to read a little bit more about the experience of these clinics, I recommend this publication, and I'm not like, it's not self-publication, you know, it's just, it was very interesting what the clinic had to say. Moving on, back to understanding the ACA. So the other thing we wanted to know is how the ACA was impacting patients with different chronic condition, including cancer survivors. We looked at patients with diabetes and patients with hypertension, but we also looked at patients were cancer survivors. And in this case, cancer survivors are the patients with cancer history on their EHR record. And it could be a new diagnosis versus a diagnosis of a long time ago. And again, we looked at health insurance. And first, we were surprised by the number of cancer survivors that did not have health insurance prior to the ACA, right here, which exceeded 30% in non-expansion state. That seems very, very large to us. Fortunately, we can see that it's shrinking with the ACA, that these, and very good in expansion state, really reduces. It's reduced in non-expansion state, but that's still over 20%. We can see the increase in Medicaid among expansion state, which kind of matches that decline in health insurance, and the increase in private insurance in non-expansion state. So there's definitely improvement for these patients who were cancer survivors, but 1 in 5 cancer survivors still remain uninsured in non-expansion state. So that's quite concerning. However, while we were investigating cancer survivors, we found that the percent of cancer survivors in our data seemed lower than expected. So it's 3% in the CHC that we were looking at versus 5% according to the CDC at the US. On the right here, you can see some of the characteristics of the cancer survivor who are in our data. So we do have a slightly younger population in these community health centers. That maybe explains it, but we still have 65% of these cancer survivors who were 60 and older. Also, the vast majority of these patients were established. So one could think that maybe we're missing a lot of information because they don't receive care following their cancer diagnosis in primary care. But for these health centers, our data don't agree with that. It seems like they get diagnosed, and within that same year, they continue to have primary care visits. And then a lot of visits. You can see that 54% had 6 or more visits in a 3-year period. So they are coming often. So what is going on here? We're really curious about what could happen. You know, So obviously we're using EHR data, so what's extractable are going to be in the field. Either there's some cancer history or diagnosis, but whatever is in the clinician notes, we are not extracting that. We do not use natural language processing. That was not part of our studies. So maybe that's what's going on. We're missing a lot of patients because their information about their cancer is in the notes, or maybe it's just because they're younger. But we did try to get some answers. So what we did is we linked EHR data from 3 states, California, Oregon, and Washington, to cancer registry. And then we compare the cancer records. And this iceberg here shows something quite concerning. First, we found that 45% of the 55%, sorry, of the cancer history matches. So patients with EHR cancer history matches cancer registry history, 55%. So that's good, but 45% doesn't. And the EHR data, at least not extractable easily, we're not going to include the exact date of diagnosis, what type of treatment, what stage. So there's a lot of information that might be lacking for the primary care provider to be able to manage the patient's health and potential increased risk for cardiovascular disease or need for more frequent preventive services. So we don't really have any answers as to why that is, but it could be still that 45% of this missing information is in the notes. That seems really high. So there is a need for more digging here. The other thing that we found about this cancer registry data differential is that it depends on the types of cancer. We found that for some cancer types like cervix, which is right here, there were more record in the EHR than in the cancer registry. And this could be because the cancer maybe was diagnosed in a different state. Like if the cancer, so we had Oregon, Washington, and California. So if someone, I don't know, got their cancer in Idaho and then they moved to Oregon, the registry wouldn't match. But that seems like a really large number to be that type of disconnect. It could be that there's some misunderstanding from the patient as to what is an abnormal test result. But the bottom line here is that if someone were to design a project to improve preventive care or some other care delivery among cancer survivors in these community health centers, they would need to really understand the limitation of these data while they are designing and evaluating their intervention. Okay, so what are the remaining health insurance gaps? Where are we today? Well, as I demonstrated in several slides, the Hispanic patients remain uninsured. And we suspect that immigration status plays an important role here, as undocumented immigrants are not eligible for any insurances, including Marketplace. But there's some movement toward changing that. In these 3 states, they are expanding their Medicaid and to adults who are regardless of their immigration status. So if you're undocumented, you can apply for Medicaid. There are different rules. Oregon is doing any adults. California is doing adults based on age, like either the younger or the older. And then Illinois is doing age 42 and older. Another potential gap for these patients is when they turn age 65. And we looked at a cohort of patients who were in expansion state and who turned 65 and continue to have visits. And what you can see is that Some remain uninsured. A lot of them got insurance, and some had like unstable insurance. They're in and out. And we found that 1 in 4 of these patients who turned age 65 had unstable insurance. And the worry part is that most of them, the vast majority of these who have unstable insurance, lost their insurance, or have no insurance, have more than 2 conditions. In fact, 20% of them have 5 or more conditions. So considering the rapidly growing population, this is very concerning, and these health centers are going to need some support to be able to care for this aging population. All right. So if you want to remember anything for today, just try to summarize it. Here are a few points that I would like you to remember. So first thing, for these health centers, ACA increased health insurance access. It improved the uptake of preventive care and had a improvement in the detection of chronic condition. But disparities remain, especially for Hispanic. Many are aging without health insurance. And we did show that we also have some issues with the EHR and incompleteness of cancer history that we need to take into account and should be addressed. And also, the pandemic had a big impact on all of us, of course. But thinking about these patients and these health centers, it is unclear to date what the true impact will be on the change in care delivery due to telemedicine, which improve access for those who have access barriers, such as transportation or childcare, healthcare outcome with those delayed preventive care. What are we going to see in the future? And revenue and insurance access with the change of the Medicaid automatic enrollment, which is projected to lead to negatively impact 10 million people. And so these health centers rely a lot on the Medicaid payments, so that could really impact them as well. I leave you with these thoughts. I just want to say and thank you. It takes a village to do all this works, and I want to thank all the partners, the large teams, the funders, and the health centers and health center leaders and clinicians who participate. There are some more findings on this website if you're interested. And thank you for your attention, and I welcome your questions.
Thank you very much, Nathalie. Very interesting presentation, excellent data. Perhaps I can start with a question that is related to your finding about very high insurance rate for Hispanic population. And even though significant cancer screening disparities for this population, do you have any recommendation to payers and providers on how to improve cancer screening and prevention for Hispanics for this population? Have you observed any barriers that are beyond health insurance, and what our healthcare providers can do to address those? Thank you.
Yeah, this is a great question. We know that there are these patients who live in these community health centers have many other social needs and social determinants that impacts their ability to care, from access to transportation, food insecurity, all of these. The Latino population may have immigration barriers. We do find that in these centers, we do find that the Latino population have a higher rate of cancer screening than the other subgroups. But we also found that a big driver of these increased cancer screening is if the clinic has a lot of Spanish-speaking patients. And we haven't done interviews, but this suggests that these clinics may have really have resources, which could be interpreters or clinicians and staff that speak Spanish, that makes these patients have higher rates. And in those clinics, the rates of cancer screening for other subgroups, like non-Hispanic, white, and Black, is also higher. So figuring out what these clinics are doing different could be helpful to help other clinics who are not doing as well. And obviously the immigration-related inability, like lack of access to health insurance due to immigration, is a big problem. Whether or not these 3 states that are doing these changes in their Medicaid expansion will work, there could be barriers for the Latino population to want to enroll in Medicaid and put their name in a state program if they do not have documentation. So I'm not sure how this is going to work. It's unclear to me why marketplace insurance must require someone to have any kind of status. I mean, they're making money. Shouldn't they be happy with that? So that's another. It's unclear to me why that is, and that impacts, the older patients who cannot access Medicare can also not access any of these plans, and they have potentially a high need for medications, things that can get really expensive really quickly.
Thank you, Nathalie. There is a question on the chat. I'm going to read it now. What resources are available to help patients navigate insurance changes and guidelines, particularly among individuals with low health literacy or individuals that English is not their first language?
Yes, that's a great question too. So not all health centers, but many of these health centers, especially the federally qualified one, can apply for grants that will basically open an eligibility specialist positions. And when these health centers, someone comes and they have a visit and they say they have no health insurance, for those who have these eligibility specialists, they will be potentially sent to either talk with the eligibility specialist or make an appointment so that they can talk about what are your insurance options. The way these clinics handle these eligibility specialists varies. In Oregon, for example, it's within the clinic, so the person can, do you want to go see this person after you're done work, you're done your visit? Yes. In California, these eligibility specialists are outside of the clinic, so that could be a little bit of a barrier. And it's unclear to me whether these eligibility specialists are bilingual, or what happened when the patients have non-English speaking. There are these other eligibility specialists anywhere that are linked to the marketplace, but again, if you don't know they exist, or then you're not gonna utilize them. But for those clinics who are funded for that, they also have to report to HRSA their frequency of helping patients. So they clearly have a motivation to help their patients, and it's always a motivation to help your patients have health insurance. So that's one pathways.
Thank you. There is another question from our members. What trends are shown in CHCs for coverage of supportive services beyond treatment, such as survivorship care to address post-treatment or long-term side effects of cancer treatment? What about clinical trials?
I don't know the answer to that. I think that just based on my experience with some of those clinics, participation in clinical trial is voluntary, or so it depends. And I don't know what the clinics post flyers for any clinical trial. The fact that we're finding such a large number of patients who have no easily accessible, quote unquote, record of cancer history. I'm not even sure if the clinicians are aware of their cancer history, depending on when it lasted. So the idea, the survivor care plan, or just what is the treatment or post-cancer treatment care, how they handle that, we're not sure. And that is something that I've been trying to figure out how to identify and get funding for. I'm still working on that because I feel like this is a really big gap that we need to better understand what is going on and how can we fix that. That seems really important, that someone should know that a patient had a cancer and they had this type of treatment, so that the clinician can be better aligned with what the patient needs. And so, yeah. And these patients may not quite understand what their treatment was either. So having someone that can provide that information a little bit better. So that is a big gap. I welcome from some suggestion to fix it.
Right. Yeah, that's true. Another question that we have, you found that 45% of data, EMR data for cancer survivors are missing. It is a quite significant number. How can providers improve data collection practices? And how can they begin actually using this data for care coordination, or along the cancer care continuum, or maybe patient navigation? Do you have any suggestions or recommendations on that?
Yes, well, the first part would be, where is it truly missing, or is it in the notes? It seems really high to be in the notes and not in at least, I don't know, the cancer history. One idea I've been playing around with is, we have in the primary care clinics have linkage with the immunization registry. Why can't we do that with cancer registry? So that there would be a direct link. They would know that, like, maybe someone could then develop some kind of tool that says, flag, your patients have been added to the registry or something, or this patient is in the registry. It seems like the registry lives there for no one to use in a way that can be beneficial for a patient and a clinician. So maybe that's an option. I'm not exactly sure how to go by doing that, but clearly they managed to do it with the immunization registries. So there is a precedent there. So that's an avenue I'm exploring. The other part would be, and this has been a debate and a difficult, something challenging to have the oncology and the primary care talk a little bit more, but that seems very difficult. So finding ways to make to have that improve somehow, whether it's again through some kind of an automated system where neither need to really be involved, but it's just something, maybe it's artificial intelligence that mine a system that would provide, we have care everywhere here in Oregon, where presumably the care that you receive anywhere can be accessed, but you have to go in and access it. If something was mining it for you and it just pops up that says, hey, patient X got treatment X, that could be, useful. Again, like, this seems like we are getting toward an area and a time where we could
data and AMR data would be quite interesting to do. Perhaps we have some time for last question. In your research, maybe qualitative research on community health centers, have you observed any effective relationship that being established between clinics, hospitals, or cancer centers for cancer patients and cancer survivors? And are there any organizational or contextual factors that help clinics to establish these relationships with other providers on the care continuum?
I have not. None of my qualitative related study looked specifically at this. That may be information derived from other implementation science centers who are within a cancer centers and have different relationship. I would say that just based on our evaluation of the pandemic, big successful clinics have a leadership that is motivated. So that might be one option. First, have the leadership motivated to be on board and do this. They see it as a priority. And then also the clinics who can do QI. So these were the two things that really helped with the pandemic. So we think that if we wanted to make these kind of relationships work, I would start there. If that works for a pandemic, then it's got to work for other things.
Well, thank you so much, Nathalie. Again, excellent presentation, very rich data, and very interesting findings. Thank you for being here today and sharing your knowledge with our members and participants of this webinar. And best of luck to you with your important research.
Thank you so much for having me, and have a great rest of your day.
Thank you. Thank you all. Appreciate being here. Thank you.